lecturing us about the menopause and obesity. And yesterday he had a very nice lecture about stress and
metabolic syndrome. Yes.
And we all hear you now.
Thank
Floor
you
is yours.
Thank you so much for your kind introduction, both of you. So I'm going to start right away about this talk, where I was asked to develop the causes and the etiology of increasing of obesity during menopause. The first part of it will have to do with the etiology of this situation, and the second will be the management. Okay, so it is true that one of the situations which is a clear fact is life expectancy increases, at least in Western countries. And in fact, menopause, which was a time point towards the end of the life of a woman about 70, 80, 90 years ago, now we're approaching to a moment when menopause is going to be almost close to the middle of your life. And eventually, if a woman has spent about 30, 35 years with hormones, supposing men start at 15 years of age and they finish at about 51 years of age, we might say women are going to spend more time without hormones than with hormones. For example, in Middle Ages, 18% of women arrived at menopause, 5% at the age of 75. Today, 95% arrives at menopause and more than 50% at the age of 75. And this is a fact. About 15 years ago, there was this beautiful meeting which has defined the stages of reproductive aging workshop. The acronym is STRAW, and describe perimenopause and menopause, not only phenotypically but also hormonally. And it is very important to understand that, to my view, one big part of the female population of which we do not take real good care, we internists and endocrinologists, is the women who spend their life between 40 and 50 years of age in perimenopause. What do we know? That during this period of life we face to rapid hypoestrogenemia. And also there are exogenous factors which happen to develop, such as unhealthy nutrition, but these are habits which start much, much earlier, and I will keep this as a conclusion to my talk, and also low physical activity. Further up, we'll see that menopause itself facilitates this lowering of physical activity. The result is that we have an increase of adipose tissue and a redistribution of fat mass from gynoid to abdominal obesity. The menopause-associated increased visceral and abdominal obesity occurs in women with both normal weight and obesity. So this is a fact having to do probably with the lack of estrogens. Are estrogens important for the deposition and the development of adipose tissue? Yes, it is. Yes, they are. Here you can see direct and central effects of estrogens, where you can see that they decrease lipogenesis, they facilitate lipolysis, and they decrease food consumption, they decrease leptin secretion, meaning that they decrease insulin resistance. So as long as women are under the influence of estrogens, their insulin resistance is lower, they have increased insulin sensitivity, and their activity and energy expenditure is enhanced. Something which we observe during menopause, but we cannot really explain. We observe that women stop really to be keen to activity and energy expenditure, and we have to facilitate this. Now here, for example, you can see and can remember going back to the days of our medical school, you can see that in all these stages where you can see the red arrows, estrogens facilitate the activation of the Krebs cycle, what we call the citric acid cycle, and facilitate the production of energy. So when they are not there, we are missing energy. And indeed, here, for example, in the left panel, maybe I can use this laser pointer. Here, for example, you can see data coming from animals which have been operated by ovarectomy and have been replaced, one group of them with estradiol. This is the group which was replaced by estradiol. You can see there those replaced by estradiol, their body weight did not change, whereas those who were overectomized, they saw their body weight going up. And when we deal also with human beings, we can see that when we replace them, females with estrogens, their fasting insulin goes down, again explaining this positive effect of estrogens on facilitating insulin sensitivity. And here I have this old slide coming from the date of the famous WHO study, which was published in 2002, a very important study, although controversial. However, this study has shown that when women were replaced with hormone replacement therapy, including estradiol, their insulin sensitivity, the amounts of their insulin went down, meaning that their insulin sensitivity was increased. And indeed, estradiol exerts a central role regarding energy homeostasis. I'm not going to go through all these details. You can see the central role of estradiol acting at different levels of the nuclei, at the level of the hypothalamus, including signals receiving from the periphery through the brain stem. And as a conclusion, I would clearly state that data have proven that estrogen acts as a powerful anorexigenic agent of the human body. Now, are there any other conditions which could facilitate the deposition of adipose tissue during menopause? Let's see quickly that first of all, as we have said, estradiol is the one which facilitates lipolysis, inhibits lipolysis. Without estrogens during menopause, lipolysis results to increase of circulating free fatty acids, and as you know, free fatty acids contribute to increase of insulin secretion, insulin resistance, and so forth. Now, I'm sorry, went back. Let's go ahead. Now, the visceral adipose tissue, which increases during menopause, is characterized by these spots, which represent macrophages. Actually, in obese people, more than 50% of their adipose tissue is composed by macrophages. Macrophages are known to contribute to increase of inflammation, and as you can see, during menopause, women, they see their CRP levels to be directly associated with their trunk fat, which represents visceral fat, in a similar way that happens in males, something which already shows that there is a change in the metabolism of adipose tissue, and actually there is, in many studies, there is a clear association of the androidal fat mass in women, represented by their visceral fat, and CRP levels. So there is a clear association of this fat mass in their viscera being associated with inflammation. And I would like just to remind you that the levels of CRP are increasing whenever one of the elements of what composes the definition of metabolic syndrome is added in a certain population. The more elements of metabolic syndrome phenotype this population presents, the more they have increased CRP. And not only they have increased CRP, they have increased insulin levels, increased the C-peptide, increased leptin levels, increasing thus their insulin resistance. Together, I'm sorry for going fast, but I have to go through a couple of slides. And together with substances which represent the inflammatory situation in these women in menopause, like PAI-1 and interleukin-6, and let's keep this in mind. So here let's see in this cartoon how the macrophages of adipose tissue, they increase the production of pro-inflammatory cytokines such as TNF and interleukin-6, which contribute to insulin resistance, as also described by the production of leptin, which also contributes to insulin resistance. How this happens, we know that these pro-inflammatory cytokines, they act in at least in two intracellular pathways. One is by blocking the intracellular cascade of insulin signaling, and two, by decreasing the production of the receptors which internalize glucose into the cell, the famous GLUT4 receptors. Leptin, as we have already said, increases during menopause, both leptin and free leptin index, but this is the most interesting thing. Leptin receptor goes down. There is at the same time, with the increase of leptin, which is due to the increase of adipose tissue, a decrease of the number of leptin receptor representing the development of leptin resistance. Cortisol. Is cortisol playing a role? We have seen yesterday the association of stress and metabolic syndrome, and indeed here we have to think again that a woman which gets into menopause is at a certain point of her life where she might have faced many difficulties, many negative effects during her life, and the effect of relative hypercortisolemia might be obvious for her. And the result is that the increase of adipose tissue by producing interleukin-6 facilitates also the production of cortisol. I'm not going to go through this in detail, but this is something that we have shown at NIH 30 years ago. We have shown that as it happens in animals, in humans, pro-inflammatory cytokines increase the secretion at the level of hypothalamus of CRH, resulting to increase of cortisol levels. And please keep in mind that when we are getting older, we secrete more cortisol. And here we have studies of humans above the age of 66, which clearly during the 24 hours study of cortisol, they have increased levels of cortisol as compared to the young group of less than 30 years of age. And how does it happen when we have more cortisol? These are studies that I have in a quick way shown you yesterday, but I would like to attract your attention as well. You can see that the more we're getting older, the size of our hippocampus, and this is a study which has used MRI, magnetic resonance imaging, is negatively associated with the levels of cortisol which have been measured in these humans by urine cortisol levels. And please just keep in mind that hippocampus exerts negative effects on the HPA axis. So when hippocampus decreases in the amount of nerves, then the negative, the inhibitory effect of the hippocampus and HPA axis is raised, and the result is that we produce more cortisol. I would like just to say that it seems that getting older is as if we're getting into an inflammatory situation. And also I have shown yesterday that in chronic stress, the HPA axis does not receive the inhibitory effect of leptin, and even though leptin is increased in these women, their HP axis is not blocked, so their cortisol further increases. And thyroid hormones, do they participate? We know, I think we're all aware that in our everyday practice that we often are faced with increased thyroid disease during climacteric and preclimacteric situation, and it's true that being climacteric and antibody positivity were associated in this big study of 2,500 women in climacteric and preclimacteric condition. They are associated with a greater prevalence of thyroid dysfunction. So the eventual malfunctioning of thyroid could also contribute to this increase of adipose tissue. So how do we treat these patients? Our way of approaching these women is no different than the way we use for all obese people, even obese men of the same age. We have to screen them and we have to assess their obesity. Here, I'm just giving you an algorithm, which I do not have the time to go through it. However, the important thing is to assess the risk factors for cardiovascular disease and diabetes, because this, as we will see in our final slide, might influence our therapeutic pharmaceutical approach. And then we have to define with our patient the goals of treatment and the time range within we are intending to apply it. Of course, we have to define the BMI category in which these women belong, and we have to be very cautious when they start getting over BMI 30, and we have to assess, among other factors, their diet, their physical activity, and their eventual change of behavior, because all of these women will tell you that they eat normally, they have the normal physical activity, and they do not really have any feeling of depression, but when you start scratching, you'll find out that their mood has changed, and this is a direct result of the absence of estrogens. So definitely we have to go through lifestyle modifications. We have to pick up the best way to approach their diet. There is a lot of discussion in nowadays having to do with newer approaches of nutrition when we wanted to lose weight. We're talking about intermittent fasting. We're talking about protein-enhanced diets. However, it seems that still what was used to be well described as Mediterranean diet, it's still the most effective approach when we want to advise our patients. So how we deal with the nutrition of menopausal women? We have to manage overweight, obesity, and try to reduce current energy by 500 to 700 kilocalories per day. We must be very cautious. We should never try to make these women lose their weight quickly. The faster they lose it, the faster we'll get it back, but we want to have them losing their weight in a regular way, and they have, in order to do that, they have also to introduce regular physical activity. We'll see how this affects our approach. So they have to avoid simple, fast-acting sugar, smoking, sugary and alcoholic beverages, sedentary life, something which can be enhanced in menopause. They have to avoid salt, and they have definitely to avoid saturated fat, and let's teach them how to read the amount of saturated fat in on their food when they buy it at the supermarket. Exercise. There are many myths about exercise. To make a long story short, people believe that by increasing exercise are going to lose weight. This is not quite true. First First, we have to establish a diet which reduces their caloric input, and then exercise will do many positive things. We have to introduce exercise, as you can see in this study. We have to achieve a certain amount of exercise during a week. I would say 3 times a week of 30 to 40 minutes of exercise should make us very happy about our patient. And as you can see here, in this very interesting study, when all groups were taken together, they were women of less than 55 years, over 55 years, BMI less than 30, BMI more than 30, weight more than 85 kilos, weight more than 85 kilos. Exercise didn't decrease their weight, as you can see here, but it decreased their waist circumference.
Sorry, Professor Mastorakos, the time is...
Yes, I'm jumping to the conclusion. Okay, no problem.
3 minutes?
Just giving, 1 minute it would be okay.
Yes,
so the idea is that by decreasing exercise, by increasing exercise, we can facilitate the decrease of visceral fat, and we can help more women who are over 55, over 30 BMI, and over 85 kilos. Okay. Let's see how hormone replacement therapy facilitates the loss of fat mass. We'll see here in this study that hormone replacement therapy increases lean body mass and decreases fat body mass. Psychotherapy can be very beneficial to these women, particularly cognitive behavioral therapy. And I'm finishing with pharmaceutical agents. And pharmaceutical agents, first of all, we must think hormone therapy. Hormone therapy has been shown positive, although it depends on the patient that we have to pick up. And definitely hormone therapy decreases visceral fat, adipose tissue around the trunk, and also the rest of abdominal fat, and decreases the inflammatory situation. You remember their CRP association, as you can see in women. After taking hormone therapy, this association was alleviated, insulin resistance improves, and then we can use all the drugs that we know for obesity, anti-insulin resistant drugs such as metformin and pioglitazone, gastrointestinal lipase inhibitors, GLP-1 analogs, which are very much in fashion nowadays, and others which are here to come. When should pharmacotherapy be used? My slide just before the last one. Obese patients with BMI over 30, or overweight patients with a BMI of more than 25 and concomitant obesity-related risk factors or diseases. When patients are unable to achieve weight loss despite their best use of lifestyle approaches to diet, physical activity and behavioral changes, and when patients' weight stabilize before the goal we have set is reached. And my conclusive slide would say that
3 minutes.
we must actively...
3 minutes more.
It's the last one. It's the last one.
3 minutes.
It's actively challenge the obesogenic environment, this meaning that we have to change the dietary habits of our patients and build physical activity into daily routines. And this is very important. This could start even by when pediatrics deal with young girls. The maintenance of a normal weight or weight gain prevention through caloric balance starting before menopause, even in adolescence. Even we have to pay attention during pregnancy. And establish lifelong habits for nutrition and physical activity. We have to start to learn how to prescribe ourselves exercise and advise for hormone therapy when appropriately, properly administered and followed up by the physician who prescribes hormone therapy. Thank you so much.
Thank you, Professor Mastorakos, actually, for this elegant illustrative talk. Questions from any audience? Yes, please. Kindly give microphone.
pose concerns about malignancy.
This is a
You mean side effects?
This is a very good question, which actually has been resolved with the study of the WHO, the Women's Health, IHI, the Women's Health Initiative, 23 years ago. What we know today is the following. If we examine our patient well, we can give this patient hormone replacement therapy without increasing the risk of breast cancer for 5 years. 5 years. After 5 years, there is an increase of 10% of the risk. It's a low risk, 10%, if you compare it to the risk of cancer with smoking. We have a decrease by 50% of endometrial cancer. We have a decrease of 50% of colorectal cancer. And eventually there is a positive, benign, positive effect in the decrease of ovarian cancer. The only negative thing doesn't have to do with malignancy. It has to do with stroke and thromboembolic events, which are rare though. They happen in about 4 women in 1 year over 10,000 women. So they are not that important. But we have to be cautious. So if our patients are obese with a BMI over 30, then we must be cautious about thromboembolic events. But for women who are less than 30 BMI, we can go ahead by customizing our treatment, and of course by watching their through gynecological examination and breast examination.
Thank you.
Sorry,
Do
one
you
more
prefer
question.
to start with GLP-1 receptor agonists, to start with GLP-1 glucagon-like peptide, or to start with hormonal replacement therapy?
That's a very good question. That's a very good question. We should never say that hormonal therapy is a therapy of obesity, because this would be silly. But we have to think in an holistic approach that if we want to cover these women, both for their bones, for their hypertension, for their insulin resistance, for their urine infections, it would be better to use just one approach than using many different approaches. However, it is true that if we deal with obesity, GLP-1 analogs are much, much better because they have a very important effect.
So you recommend routine hormone replacement therapy for that beneficial effect and protective effect?
I would be cautious about the use of the word routine. I would say customized.
Okay.
So we check our patient, we discuss everything, and also a very important thing, because we're in a country with different levels of cultural approach. We have to know whether our patient wants this treatment, and she's an active member of the society who could really benefit from this treatment.
Thank you, sir. You have a question?
Sorry,
Yes,
one
you're welcome.
question more, maybe a very important one.
Yes.
Do you think that we should start with HRT in a late menopause or just in peri and around menopause?
Beautiful question. Of course it is important, always coming from you, my dear Tatiana. The first thing, according to the straw, that we are losing in premenopause is progesterone. And then we lose estrogen. So the first thing we should start in these women would be progesterone. Progesterone has nothing to do with adipose tissue and obesity, but it has many things to do with mood disorders because of the production of neurosteroids in the brain. When we lose estrogens, that means we are in menopause, then we should continue with hormone therapy. After 10 years of menopause, then this has not been studied. Unfortunately, we do not have studies with comparing women over 60s. Yeah. No, I responded, I thought it was about premenopause. No, we do not have studies over 60s. Yeah.
Okay, thank you,
Thank you
Professor
very much.
Mastarakos.